It's my great pleasure to introduce our next speaker, Dr. Rick Kingston, PharmD. The focus of Dr. Kingston's research, service, and education efforts has been in the area of clinical toxicology and consumer product safety, including regulatory policy making in all issues related to the safe and effective use of consumer products. His research and practice interests coincide with those of his colleagues at their practice site Safety Call International PLLC, where they provide corporate clients and manufacturers with authoritative, state-of-the-art post-market surveillance support. It has been Dr. Kingston's goal to educate his students as to how they can use their training to help companies design, market, and monitor for safety in a variety of consumer products that will meet their intended use without injuring or adversely impacting consumers, their pets, or the environment. In addition to advising the consumer product markets that include EPA and CPSC regulated products, Dr. Kingston has a specific interest in poisoning data collection systems, as well as interpretation of incident data depicting the safety of drugs, dietary supplements, and botanical containing natural products. Please join me in welcoming Dr. Rick Kingston.
Thanks very much, Paloma. This is a great opportunity, and I really appreciate having the opportunity to address you folks today. One of the things that Paloma didn't mention is that I was the director of the Minnesota Poison Center for 17 years, actually co-founder and director. And I was on the inpatient toxicology service at the time, which is at St. Paul Ramsey, our regional level 1 trauma center on the east side. And funny story, when I first got involved at the medical cannabis program, I was going to check and see how other people felt about it, because I had a fair amount of experience in dealing with patients that had come in and had cannabis and along with other types of substances. I felt pretty comfortable with it. I mean, from a safety profile generally. But I met with the police chief of the Stillwater Police Department, and I was saying, well, what do you think? Are you worried about this? And do you think that this should be legalized, so to speak, for this program? And he says, well, I'll tell you what. Over the years, I've had a lot of experience with cannabis. I've also had a lot of experience with alcohol. Whenever I come across a bunch of young guys that are consuming alcohol, they want to start a fight. And when I come across a bunch of guys that are consuming THC or cannabis, they want to start a band. And so he said, I am absolutely 100% behind legalizing this and getting tax revenue for the benefits of a product that makes sense. Second story, when Kyle Kingsley was anticipating getting into this particular area, he put together a proposal that was going to be submitted to the Minnesota Department of Health. And his thought was he wanted to make sure he had all his bases covered, so he sent it to a mutual colleague of ours, another family medicine physician, and who I had worked with in some different areas. And he said, we think this proposal is great. Can you take a look at it and tell us if it's pretty complete and everything? And he says, he read it and he says, this is a great proposal, but you got one thing you're missing. He goes, what's that? He goes, post-market surveillance. You don't say anything in here about how you're going to monitor what happens once the product gets in the hands of consumers. So I said, so his buddy, our mutual friend, said, I'll hook you up with someone. So he calls me up and says, here, why don't you meet with this guy? He wants to put in a proposal for the medical cannabis deal. And we met, and it was really a very interesting experience because he was gung-ho and said, this makes perfect sense. So we helped him put that component into it. And when they actually submitted their proposal to the Minnesota Department of Health, it was the top proposal of all the applicants that came through the system. So I had a small part in I hope, helping them get off the ground. Maybe one thing just to mention in terms of safety calls, just in terms of our backdrop. We're a 24/7 human and animal adverse event medical contact center. So we provide essentially outsourced medical affairs department for corporate clients that have products. So if you look on the 800 number on the back of the product label, everything from pesticide to toothpaste to drugs to dietary supplements, we just dominate the market. We have over 200 corporate clients, some of the largest in the world. So we get to see a lot of adverse events in general and what happens with products in the marketplace. It kind of builds on my experience when I was the director of the State Poison Center. We also have a 24/7 veterinary poison control center. we have there's a service called Pet Poison Helpline. If your dog or cat or sugar glider got into something and you called your vet because it might be a poison, pretty good chance that they would refer you to our center. We have like 50 veterinarians and about 60 certified vet techs that support that particular area. The other thing that's unique about this is that we're a triple licensed healthcare practice. We're licensed by the boards of medicine, pharmacy, and veterinary medicine, which is the only practice like that in the country. We actually had to get a special dispensation from the licensing boards to have those three professions in the same medical practice. You don't normally think of having veterinarians in a medical practice with either pharmacists or physicians. And the licensing board said it makes perfect sense because toxicology is a multidisciplinary practice. We're also academically affiliated with the University of Minnesota. I maintain a full academic appointment there, and also the University of Mississippi and the National Center for Natural Product Research. So we really have a big academic focus as well. I wanted to give just a quick primer on adverse event reporting in general. I mean, what is it that we're looking for? Why do you need it? Why is it important? A lot of times people say, well, we've tested this product before it goes to market. We feel comfortable with it. We've had placement studies and everything, and so we're ready to go. What I always remind them is that when you do a placement study, you don't do a placement study in 10,000 people. You do it in maybe 50 people. And if you have an adverse event, a serious adverse event that occurs in maybe one out of 10,000 people, you have to study at least 3 times that number to get the likelihood of having one case in your case cohort. So your marketplace is really your final destination where the product demonstrates its safety profile. So you need to monitor that and make sure that it's providing the intended benefit without unintended consequence. So that when I talk about this, a lot of times people, when they hear about mandatory adverse event reporting, they think that's post-market surveillance. In other words, if the government requires you to submit an adverse event report, the assumption is, well, your job is done. You just let somebody else take a look at your products and see if there's an issue. It's a very, very different process. If we look at mandatory adverse event reporting, it's really a descriptive process. So you receive reports of adverse events, you document them in a database, you tabulate the information, then ultimately you submit it to a regulatory body. That's a very prescriptive process. That's not the same thing as post-market surveillance. In order to even put that system together, what a manufacturer needs to do is they have to design a database to manage collected reports. They have to design an intake system and policies and procedures for triage of calls or cases to appropriate designated staff. Then they have to implement a system to manage and document all incoming incidents from all likely methods of consumer communication. It's changed drastically, even in the last 5 years. You get so much information now that's even coming in on Facebook pages, social media, emails. It's not just phone calls that we're dealing with. And then you have to ensure that all regulatory reporting obligations are met, including expedited serious adverse event reports and where reporting is required. You typically have that with EPA products, with FDA products, depending on the particular category. So a lot of times you'll talk to a manufacturer and they say, well, we got this stuff, we're going to document everything. And so they do that. And so then they report whatever they get. And they don't seem to understand that somebody's going to look at that data, and it better be them, because they need to know what's happening with their product once it gets in the hands of consumers. So what we do is we help take that manufacturer from that mandatory reporting obligation and transition to a process of looking at your adverse event experience and doing trend analysis, benchmarking, and signal detection. Especially when you're dealing with spontaneously reported adverse events, there's a tremendous amount of background noise that occurs. And it all depends, too, on the class of product that you're dealing with. Dietary supplements, for example, we get a lot of spontaneous reported adverse events that really are just background noise. It's estimated that of the serious adverse event reports that come in and are ultimately reported to the agency, there's probably only 1 or 2% that actually signal a potential safety issue. The balance of that falls into the background noise area, which I'll mention a little bit more in a minute. So you want a trend analysis, you want a benchmark, and you want to use it for signal detection. So the 3 things that a manufacturer should look at, and I don't care if it's a cannabis manufacturer or a toothpaste manufacturer. What's the benchmarked and expected incident rate for any given product's adverse event rate, and over time, are there significant deviations from minor, moderate, or major outcomes? Every product, what I've found over my 40-year career is that every product has its own profile. And what will happen is, as it gets into the marketplace, you get a bump in number of adverse events, and once consumers get familiar with it, that kind of normalizes out. So you need to be able to monitor that, so you look for deviations to see if there's something unique going on with the product that you hadn't seen before. The second is the observed incident rate a true reflection of expected consumer reactions when using your product, or are the reports simply background noise? And I'll talk about that a little bit more. Then lastly, is your product actually causing your customers or patients to have adverse events or adverse effects? How serious are they? Can they be mitigated? And if not, do they represent acceptable or unacceptable risk? That's probably the most difficult decision that either a company, a regulator, or a consumer asks, is trying to get an answer to, because almost everything has got some level of risk associated with it. I don't care if you're selling water. You know, you could have a water product in the marketplace that ends up being contaminated with a pathogen, and you end up having a major problem with it. Or it could have inherent, you can have water intoxication. We have, psych patients that sometimes engage in that kind of behavior of taking in large quantities of water, which can cause severe metabolic imbalances of your electrolytes. So it's watching for those types of things that's really important. So we really look at it as the art and science of signal detection, and then looking at what those trends look like and what kind of adverse events are coming in. When I look at any company, and I'm looking at their adverse event data, some of the things that I want to look at, number one is the normalized incident rates. And then what I mean by that is that a lot of times when you see reports that come out of the medical literature and they talk about they had 25 patients that had XYZ happen, or they had 10 patients or whatever the number is, they're always living in the numerator because they don't know how much product is in the marketplace. You know, most companies, that's proprietary information. You know, it's not that that's confidential business information in terms of how much product's out there. Drugs, not so much, simply because you have monitoring systems that you can take a look at what the use patterns are and how many prescriptions are being filled for various pharmaceuticals. But for other consumer products, where you get a lot of spontaneous reported events, you don't typically have that luxury. We're fortunate because we have that luxury of getting that data. So we get the data from the companies, and so we can actually see what their normalized incident rates are. So I may have a company that's got 10 what appear to be serious adverse events, and everybody's all up in arms, and they say, well, how much product you got in the market? Well, about 500 million servings. Okay, well, that's a little different than somebody having 200 products that are out there and getting the same number of adverse events or patients. So you have to normalize your incident rates. Then you have to determine acceptable ranges and actionable variations. At what point is this much too much? Again, that's always the challenge, to try to make that determination. The other thing is determining expected events based on the toxicology and the product design. Product design makes a huge difference in terms of how people either use the product or are exposed to it, and different products, even with the same active, can have different formulations in the marketplace that give rise to different levels of reports of adverse events. So understanding the toxicology of the ingredients and how that product is designed is going to be important. Then you want to look at identifying predictable events and their expected incident rates. So there's certain types of products and certainly drugs that we know that there are certain types of adverse effects that are going to be expected. In the majority of cases, we're not talking about life-threatening ones, but they can be, depending on the type of drug or the class of product you're dealing with. If you look at oncology drugs, pretty high chance that you're going to have everyone has an adverse event that takes an oncology drug. That's just the reality. What are they? How serious are they? And are they above what would happen if the person wasn't receiving the drug? So you have to take a look at the risk-benefit. It's always risk-benefit. The other thing we look at is the incident integrity score, and consider that most direct from consumer healthcare products events are spontaneously reported by consumers versus clinical trial generated. So most of the consumer products that you've got in the marketplace, they may or may not have a mandatory reporting obligation. A lot of cleaning products, for example, don't have mandatory reporting to the CPSC. Companies will typically put in their own stewardship programs because they're best practice companies and they want to make sure that their product is meeting its intended need without unintended consequences. But the background noise or events occurring simultaneously but unrelated to product use is something that's very, very important to be able to sort out. Dietary supplements is a good example simply because people take dietary supplements oftentimes as lifestyle products for extended periods of time. So their opportunity for exposure is really pretty high. If you think about it, someone's on it for 15 years or 20 years or a probiotic, and all of a sudden they have some condition that they developed. And the last thing that they remembered that morning was that they took their probiotic. So you end up with these I wonder if. And so your sensitive surveillance systems pick up those kind of cases, but it's actually sorting out that background noise to determine if that actually signals some type of an issue for us. The other thing is identifying trends in low-scoring unexpected events and considering potential relationships to product issues. And these are what we call sentinel events. Sentinel events are those types of things as the canary in the coal mine. Is there something unique about this particular event in terms of when we measure it, looking at standard factors of association, whether it's expected or whether there's a biologic, pharmacologic, physiologic explanation for it? Is there de-challenge and the effects go away, or re-challenge, do they come back, and what are the confounding variables? When you look at those types of things, you need to be able to striate your data so that you can look at each one of those particular pathways and figure out if there actually is a sentinel event. It's kind of funny on the sentinel events front. I remember being at an FDA conference where one of the high-level FDA officers was up talking about revamping some of their adverse event reporting. And one of the things he said, which I didn't understand where he came from, he says, "We're not really interested in all these minor stuff. We just want you to report sentinel events." You can't report just sentinel events by just looking for sentinel events. You have to report the entire experience and look at the entire experience. What we do in our system, we actually just published our methodology a couple months ago in the Journal of Regulatory Pharmacology and Toxicology. It's really designed to look at those standard factors of association for each of the events that come in, especially for the more serious types of events. And in some cases, they get a low score, but identifying trends in low-scoring unexpected events and consider potential relationships, that's what you're looking for with the sentinel event approach. Then let's say you do have a suspected sentinel event, or for deviation in expected incident rates. Do the individual incidents represent a quality control issue or contamination? And this could be a pathogen or adulterant. So what I always talk to companies about is they say, our products are so safe, they're never going to have a problem. I said, well, you don't know what's going to happen when it gets in the hands of consumers, and the way that they use it, and the way that they mix it with everything else under the kitchen sink. So you need to be thinking outside the box. So quality control, is there a pathogen problem? If all of a sudden you're seeing a huge uptick in GI types of effects, and hopefully it doesn't get to an elderly patient that would end up potentially becoming dehydrated from that, you want to know that as soon as you can. You could have direct but predictable or previously recognized adverse effects based on the inherent toxicology or the pharmacology of the product. These can be either dose-dependent or dose-independent. Your dose-independent types of cases more often than not are immune-mediated, and we see a fair number of those with an allergy type of approach, for example, or an allergy situation. You could also have direct but previously unrecognized adverse effects on the product or the ingredient. And in this case, it can be idiosyncratic, and that means it's unpredictable in occurrence, but predictably occurring at a low incident rate within the patient population. And idiosyncratic reactions, by the way, they're called idiosyncratic reactions because we just don't know. There's something happening, we just don't know what it is. We call it idiosyncratic because we can't figure out what it is. But when your numbers start increasing, you start needing to really look for those mechanistic things that might be helping you understand why that product is producing the effects that you're seeing. You can also have long-term effects secondary to chronicity of use. Good example, phenytoin, for a seizure disorder. People that take phenytoin long-term, you're going to have gingival hyperplasia. It's just a normal finding that you have in those particular patient populations. The other thing to consider is that there might be interaction-related events involving use of the product and other disease, other drugs, disease, food, environment, biologic, such as the gene expression, HLL allele mutations, and P450 enzyme aberrations. Those are things that I think is going to be the most exciting thing for the future, helping us understand more about these, quote, idiosyncratic reactions. I just got back from the conference from the National Center for Natural Product Research from last week, and they presented a series looking at green tea extract. And what they found in their series of patients that ended up with severe liver damage is that it was, I think 100% of the patients that had this had a HLA B3501 allele gene mutation. So it meant if you had that mutation, you were more likely than not going to potentially have that particular effect or could have that effect. If you didn't have that gene mutation, you're home free. So we may be able to map those types of alleles over time, and you may be able to have a list be able to identify products that, can be toxic under certain circumstances like that. The last one I was going to mention here is, not only the consumer product concomitant, but counterfeit products is also another issue. You would be surprised at how good the counterfeiters are. If you have a product that's got a high value on it, it's ripe for counterfeiting, and it looks better than the original. It's amazing. I've seen a number of these that we picked up over time. Then the last thing is, can the reported effects in any given category be prevented, managed, or mitigated? Either you take a look at disclosure, education, reformulation, new manufacturing processes, new product design, dosage adjustment, and last, not least, is market withdrawal or recall. And I do a lot of health hazard evaluations for companies that have got some type of a deviation in the product. And making a decision on when you want to recall a product, it's got a lot of consequences to it. You don't want to recall everything if there's just a really super minor specification issue, but you need to be able to protect the public too. So that's another thing that's going to be important. And then lastly, not all adverse event reports are created equal, and not all adverse event reports are background noise. That's the one thing I always tell our clients, that if we're seeing something, we need to figure it out what's going on. And that's where I was talking about the standard factors of association applied to patient profiling and association scoring, where we look at these standard factors to help sort out those cases. And as I mentioned, we just published our correlation scoring system, so I think a lot of other folks can take a look at it. Maybe it'd help them as well. So I want to shift now and just end up with the Minnesota medical cannabis legislation and what's happened subsequent to that. This is one of the most interesting pieces of legislation that I've seen, because at the bottom they ended up with the patient safety requirements. So if you look at the actual law, that first of all, they borrowed a lot of information from other data systems, such as the Canadian system for natural health products. And I actually had something to do with that. I was helping the health department try to figure out how they're going to put together a surveillance system. And the adverse event means any negative medical occurrence in a person after using medical cannabis, either physical or psychological, including any harmful reaction, symptom, or disease. So it's a pretty broad-reaching deal. This is the one that really surprised me. Persons who must report any serious adverse events are a registered patient certifying healthcare professional, a registered designated caregiver, or a patient legal guardian. I've never seen a requirement that a patient actually has to report. They enter a contract that they have to report adverse events. This is one of the most robust systems that I've ever seen in terms of all the markets that we monitor. And then the reporters named in item A must report to the manufacturer where the patient's medical cannabis dispensed within 5 business days. This is pretty prescriptive. So this is one of those cases where you may actually have, I wouldn't say over-reporting, but you've got a very robust, sensitive surveillance system. The other thing is that they require that the manufacturer maintain a toll-free telephone line which must be available 24 hours a day, 7 days a week, that is staffed by professionals who are healthcare practitioners or state-licensed pharmacists trained in detecting, assessing, understanding, and preventing adverse effects on any other drug-related problems. That's pretty incredible that they have that level of detail and specificity that they put into their system. And then they're just talking here about the follow-up on serious adverse events and document all follow-up activities. And then the manufacturer reports by the 5th day of every month. They have to let the health department know what's going on, plus an annual summary report, which we end up writing with the companies. So final safety step is patient surveys on each visit to the dispensary, including patient self-evaluation, questionnaire, frequency and duration of medical cannabis purchases, use patterns, and so forth. When we went, we were asked to present our CBD experience to the FDA when they had their CBD Symposium, the public meeting in Washington. And so at that time, we took a look. We had 26,000 patients enrolled with detailed medical experience. All spontaneous reported AEs managed and documented 24/7 by a single entity statewide, which was our practice group. And then reports of serious AEs documented in detail with medical record review. And what we found was that for the CBD-only products, there were no serious adverse event reports. All AEs, non-serious, judged as unlikely associated with CBD. We had 2 patients reported sleepiness, self-limiting. 1 patient reported trouble sleeping. Overall incident rates is 1 adverse event for every 1,700 units sold, and 1 AE for every 123,976 doses. That's a pretty incredible safety profile. We also took a look at the balance of the combination THC and CBD, and then CBD only. Your overall incident rates: 39 AEs for every 100,000 units sold, 2 AEs for every 100,000 sold. Again, pretty incredible numbers. And then we took a look at, I just pulled the data from our two most recent reports. We had 47 cases in 2020 and 2019-20, and 46 in 2020 to 21. Pretty similar. The interesting thing is that our minor outcome patients, with 60% initially in through the 2020 cycle, and 78%. Moderate outcomes, only 10 patients, 22%. Major outcomes, 0, and death, 0 patients. That's a pretty incredible safety profile if you take a look at it big picture. You won't be able to see this. It's kind of hard to read, but basically what we did was identified all the different types of symptoms that were being reported. And the thing that's, I think, important to look at is that the numbers of patients that we're talking about, one patient, and many of these are reports of events that occur in one patient, multiple effects. So you can see it's kind of all over the board, which is what you typically see with a sensitive surveillance system. You see all kinds of situations like that. This is just one additional, follow-up. You'll be able to see this if you get the slides afterwards. But I just think that it's really important to know just how much safety has been built into this program in Minnesota, and the information that we can mine to help educate policymakers on a national level and get involved in that particular conversation. So with that, I think I'm on time.
Great.